Hi guys, this is our Lab 14 review, the anterolateral abdominal wall and inguinal region lab review for anatomy. Let's get started. Excuse me. Just a quick reminder, I think this doesn't get said enough given that, we're in med school, but this is really hard and you got this, right? So keep on keeping on. This isn't an easy thing to do, and learning all this material so quickly is hard, but we're very capable overall. All right, so for this lab, we had really 4 different muscles that we need to know, and here we have them from superficial to deep, with the exception of the rectus abdominis. And we'll go over each one of these a little bit more in depth in just a minute, but here they are on a front slide so you can refer to them easily in this review document. The start of the slab obviously is reflecting back the skin, and so can you describe the fascia of the anterior abdominal wall? Well, here we have sort of the front view, and then I added a side view to make it a little bit easier, but from superficial to deep, we have the superficial fascia fatty layer called the Camper's fascia, and then deep to that we have also another superficial fascia layer, the membranous layer called Scarpa's fascia, and you can see those two right here. So Camper's fascia, this fatty layer, and then Scarpa's fascia, this membranous layer. All right, deep to that, we have our external oblique, and each of these muscles is going to have fascia, its own deep fascia, so fascia underneath it, and you can see that here. So this is our external oblique. Then deep to that, we have the internal oblique right here, and that will have its own corresponding fascia. And then deep to that, we have the transversus abdominis muscle, which is right here, and it will have its own fascia right there. And then further deep to that, we have the transversalis fascia, and that covers the innermost surface of the deep anterior wall muscle layer. It's derived from the thoracolumbar fascia, which we'll see a little bit later, but from basically the small of your back, the fascia there. All right, deep to that, we have extra peritoneal fascia, and then deep to that, we have our parietal peritoneum, which we can see here. So overall, to review, we have our skin, then we have our Camper's fatty fascia, then we have our Scarpa's membranous fascia, then we have the deep fascia for each of our 3 muscles, then we have transversalis fascia, we have our extra peritoneal fascia, which is mostly fat, and then we have our parietal peritoneum overall. All right, so that's the layers of the fascia, and then we have our muscles starting with the external oblique, and you can see that it's right here, and it leads into an aponeurosis, which we know in aponeurosis is just like a flat tendon. And so our external oblique has its origin in ribs 5 through 12. It's going to insert along the iliac crest. It will form the inguinal ligaments and connect to the pubic tubercle, and then insert on the linea alba through the center of the abdomen. All right, and then its innervation is from the anterior rami of T7 to T12 right here. So T7 to T12. And those are the anterior rami of those spinal nerves. All right, then in terms of the action for the external oblique, the most superficial of our muscles here, we have compress the abdominal contents during maximum breathing out, expiration, coughing, and also compress the abdominal contents during pooping. All right, then we also have trunk flexion and rotation. All right, let's just take a quick look at the external oblique. All right, so here we have the external oblique. Here's the other one. Let's see if we can isolate the nerves. All right, and so we can see the nerves innervating this guy. All right, so 9 through 12, and then let's see if we can take a quick look at our arteries. All right, so we can see posterior intercostals, and then we also have parts of I believe these are the superior and inferior epigastric, which we see here in the front. All right, not too bad. So that's our outermost muscle, external oblique. Then we have the next layer down is the internal oblique muscle, and we can see that the internal oblique has its origin actually down here with the thoracolumnar fascia, which is here in the back, and then the iliac crest, and then the lateral 2/3 of the inguinal ligament. It's going to insert along the inferior border of the ribs, 9 through 12, and then along the linea alba and along the pubic crest right here, and then continue along the pectineal line through its aponeurosis. And then, just as a quick reminder, our pectineal line is right here, adjacent to the pubic crest that it inserts on. All right, and then in terms of innervation of the internal obliques, it is T7 through T12 plus L1. So T7 through T12 and L1, the anterior rami from these spinal nerves. All right, and then important thing to know, the aponeurosis of the internal oblique fuses with the aponeurosis of the transversus abdominis to form the conjoined joint tendon. And so we can start to see that here. We have the transversus abdominis and then the internal oblique, and they're fusing to form the conjoint tendon right here, which we see is meeting up with the aponeurosis of the external obliques at the linea alba right here. All right, so in terms of action, it's the same as the external oblique. Compress the abdominal cavity during maximal expiration, coughing, and pooping, and then trunk flexion and rotation overall. All right, so let's just take a quick look at the internal oblique. So I'm going to hide the external oblique, and here we have the internal oblique. Let's just take a look at the nerves really quickly. All right, so we see our intercostal nerves overall, and then we have our arteries. We have intercostal arteries, and then we have the superior and inferior epigastric in the front. Don't think this one does the best job of highlighting the arteries overall. All right, let's go back. So then after that, we have, even deeper to that, we have the transversus abdominis muscle. We can see that it also leads to an aponeurosis, which we know eventually fuses with the internal oblique aponeurosis to form the conjoint tendon, which eventually meets up at the linea alba with the aponeurosis of the external oblique. The origin of the transversus abdominis is the same lumbar fascia back here. Then we have the costal cartilage of the lower few ribs, so you can't really see them here, but lower few ribs 10, 11, 12. And then its insertion, it's going to be inserting on the linea alba, the pubic crest, and then the pectineal line, which we saw earlier. And then just like the internal oblique, its innervation is T7 through T12, and then L1, T7 through T12, and L1 overall. All right, action is exactly the same. Compress the abdominal contents during maximum expiration, breathing out, coughing, and defecation. All right, so let's just take one quick look at that, and then we're almost done. So I'm going to hide the internal oblique. And we have our transversus abdominis muscle, you can see right there. See if we can isolate the nerves. All right, we see our intercostal nerves overall. And let's take a look at our arteries. I'm guessing it's going to show, yep, exact same view as the other one. Our superior epigastric coming down and our inferior epigastric coming up, branching off of the iliac artery. All right, so that's that. Then we're going to talk about the abs. So we have the rectus abdominis, which we're very familiar with, these guys right here. The action of the rectus abdominis is to also compress the abdominal contents during maximal expiration, coughing, and defecation. The innervation is T7 through T12. Its origin is along the pubic crest and the pubic tubercle. So pubic tubercle right here, pubic crest right here, and then pubic symphysis right here. Its insertion is on the costal cartilages of ribs 5 through 7, which we can see here, 5, 6, and 7 on the costal cartilages, and then also along the xiphoid process, and then it's innervated, I think we already said, T7 through T12. All right, let's take a quick look at those guys. So we have our rectus abdominis muscle, and let's take a look at our nerves. All right, so we have our nice intercostal nerves, innervating it. All right, and then blood supply. We have our superior and inferior epigastric artery overall, which we'll talk more about in a little bit. Okay, so those are our muscles. Then we have the rectus abdominis is actually covered by a sheath anteriorly and posteriorly. And so if we go here and we add our connective tissues, so you can see that on the front we have our, I think we're one layer too high, so that one. All right, well, we'll just show it in this instead. All right, well, we have our, basically the aponeuroses from our three different muscles, the external oblique, the internal oblique, and the transversus abdominis are going to come together and form the anterior and posterior rectus sheath. You can just see it's, going around the rectus abdominis and meeting at the linea alba. But the rectus sheath is just dense connective tissue that encloses the rectus abdominis. The anterior and posterior layers are formed by the aponeurosi of the external and internal obliques and the transversus abdominis. They meet at the lateral edge of the rectus abdominis, called the linea semilunaris, and fuse at the midline, which we know is the linea albus. All right. Importantly, though, we do have a distinction above and below the umbilicus for the posterior rectus sheath, and you can see that here. So at the arcuate line, this is our posterior wall of the rectus sheath, and then anterior we'd have covering this part right here. But you can see that the posterior wall of the rectus sheath doesn't continue all the way down, and is eventually you just have the transversus fascia as the posterior rectus sheath stops. And so this roughly occurs below the belly button umbilicus at the arcuate line. The aponeurosi stop, contributing to the posterior rectus sheath, and the rectus abdominis, this muscle instead, is going to contact the transversalis fascia instead. And so you have above the arcuate line, you have our posterior and anterior rectus sheath from our three muscles, and then below the linea alba, you do not have the posterior rectus sheath. The three muscles are contributing to the anterior rectus sheath only through their aponeurosi. All right, so then what if we go further down? What lies deep to the anterior abdominal wall? Well, we've already started to see this. We had our side view of the different fascia. So we said, skin, then you have Camper's fascia, which is kind of fatty, Scarpa's fascia, which is membranous. Then you have the three muscles, and they each have a fascia deep to them. And then you have the transversalis fascia. Then you have the extraperitoneal fascia, which is mostly fat. And then you have the parietal peritoneum. And so we see that here. We have below our rectus sheath, we have the transversalis fascia. Then we have our extraperitoneal fascia. And then we have our parietal peritoneum on the inner surface of the abdominal cavity, and notice how that is continuous with the visceral peritoneum when it goes and encapsulates the GI tract and GI organs. Okay, so not too bad, just continuation of what we already knew. Can you discuss the nerves of the anterior abdominal wall? And so, this is relatively straightforward. It's really just dealing with the nerves from the vertebrae. And so you have the nerves of the anterior abdominal wall course inferiorly and medially, right? You can see that they're coming down within the neurovascular plane, which is between the transversus abdominis and the internal abdominal oblique, right? So you can see right here we have the transversus abdominis, and then we have the internal abdominal oblique, and our nerves are running on top of the transversus abdominis. And you can see that we have T7 through T12 are innervating this area, and then we have L1, so they're all coming from the spine. T7 through T12, or anterior rami, are called the thoraco-abdominal nerves, and again, you can just see they're running inferiorly and medially. And they're going to innervate all the muscles of the anterior abdomen, so our three muscles that we've talked about, and the rectus abdominis. Then we have the T12, which is also called the subcostal nerve, and then L1 has two branches, the iliohypogastric nerve and the ilioinguinal nerve, and the ilioinguinal nerve is going to go into the inguinal canal and supply, innervate the anterior scrotum and the labrum majus for women, and the upper medial thigh. All right, for dermatomes, it's relatively straightforward, but our lecture wanted us to know that the xiphoid is at T7 or T6, depending on your source. It said not to worry too much about which one it is, other than know it's roughly T5 or T7 or T6. And then the umbilicus is at T10, and then the pubis is L1 through the iliohypogastric nerve. Okay, so not too bad. Arteries of the anterior abdominal wall are a little bit more complex. I tried my best. So basically, we start with the internal thoracic artery, which you may remember from our discussion of the thoracic cage. It's running posterior deep to the right here behind the sternum. That will branch into the superior epigastric artery and the musculophrenic artery, which we know supplies a portion of the diaphragm, as well as you can see here, anterior intercostal. The superior epigastric is going to meet up with the inferior epigastric, which branches from the iliac artery. We know the iliac artery is really the fate of the descending aorta. You also have the deep circumflex iliac artery, which is also coming from the iliac artery itself. And then here we have the iliac artery, which we know is from our descending, it's the fate of the descending aorta. All right, important thing to know, the superior epigastric and inferior epigastric, we can see that they meet up here. They actually anastomose within the rectus abdominis instead of in between the rectus sheath, and we can see that the superior epigastric artery descends within the rectus sheath, so on top of the rectus sheath, actually. Here's just an example of the external iliac artery down here, which we can see is coming from the inferior epigastric artery is coming from the external iliac artery just above the inguinal ligament. All right, and then here's just a zoom in of that. We have our common iliac, our fate of the descending aorta, and you can see that's turning into the external iliac, which is continue into the leg, and then we have our internal iliac, but our inferior epigastric is going to branch off of the internal iliac overall, and then we also have our deep circumflex iliac artery. All right, so here's just another version of that exact same thing. So starting with our internal thoracic artery, which is branching off of the right subclavian, which comes from the right brachiocephalic, which comes from our aortic arch. The right internal thoracic, we remember, is descending just behind the sternum, or adjacent to the sternum, on the anterior part of the thoracic cage. This guy is going to break up into the superior epigastric and the musculophrenic. We said musculophrenic is doing some diaphragm. We also know that we have the periocardiophrenic, which is doing most of the diaphragm for supplying blood, but musculophrenic does diaphragm and then rectus abdominis, and so does the superior epigastric. Musculophrenic is also doing some intercostal blood supply anteriorly. Our superior epigastric, coming from right internal thoracic, coming from right subclavian, is going to anastomose with our inferior epigastric artery, which is coming from our external iliac, which comes from the right common iliac, which we know is an extension of this whole guy, which is our epigastric artery. Then we still have posterior intercostals coming off, or I said this is descending aorta overall. Then we still have posterior intercostal arteries coming off the descending aorta. All right, also coming off of our external iliac, we have our deep circumflex and our superficial epigastric. All right, so that takes us to veins, and we had kind of a cool clinical correlation here, which is dealing with the portal vein, right, the vein that's leading into the liver. And so, why are the veins of the anterior abdominal wall important to know? Well, we might see clinical correlation, which is the caput medusa, caput meaning head, but these hugely distended veins as a result of portal hypertension associated with the liver. So we have our lateral thoracic vein coming down. This is coming from the axillary vein. That continues and becomes the thoracoepigastric vein. Branches of the thoracoepigastric vein are going to anastomose with the paraumbilical veins, which is going to go into the portal vein, which is going to be connected to our clinical correlation in just a minute. From towards the feet, we have the superior epigastric artery and vein coming up, and basically the idea is that this superficial epigastric vein is going to meet up with the thoracoepigastric vein, and so here you have ventral drainage into the superior vena cava. Down here you have drainage into the inferior vena cava for blood return. All right, so this is just more on the exact same thing, just pointing out a couple of things. So this is probably the easiest for you to start with. We're familiar with the right brachiocephalic. And then we have our left brachiocephalic right here. The right brachiocephalic is going to give us the internal thoracic, which travels right behind our and the anterior part of our thoracic cage, right behind the sternum. Then our auxiliary vein is going to branch and give us our lateral thoracic vein, which is going to come down and become the thoracoepigastric. That will continue and meet up with the superficial epigastric, which will drain into the iliac, which will go back to the inferior vena cava. All right, but here, this guy right here, internal thoracic vein, we're more used to talking about him. Lateral thoracic vein, though, is going to give us most of the veins that are very superficial, and the thoracoepigastric, coming from the lateral thoracic, is going to have branches that go and meet up with the paraumbilical veins, and so the paraumbilical veins are going to meet up with the thoracoepigastric, which we can see the superior epigastric and inferior epigastric veins are basically names for thoracoepigastric. Those are going to meet up with the portal vein, and the all of these small veins we call the paraumbilical veins. So our thoracoepigastric is going to meet up with our portal veins, and then if you have portal hypertension, basically this is going to cause the paraumbilical veins, all of these guys, and the thoracoepigastric tributaries to enlarge, and then you get these hugely distended veins, which look like the snakes on the head of Medusa from Greek mythology. All right, so this is just another view of the veins. We're familiar with the internal thoracic coming right behind the sternum, but we also have from like HBF1, Unit 1, we have our lateral thoracic coming down as well. All right, and then just a quick note on lymphatics. Superficial lymphatics in the anterior abdominal wall drain into the auxiliary lymph nodes up here, and the superficial inguinal lymph nodes. So it's a superficial lymphatics from the abdominal wall muscles drain into the posterior intercostal and inferior epigastric vein to reach the parasternal and external iliac nodes. All right, so above the umbilicus drain into the auxiliary lymph nodes, below the umbilicus drain into the superficial inguinal lymph nodes. All right, that brings us to really the final concept, which is the inguinal canal. And so the inguinal canal is a canal in the lower abdominal wall through which nerves to the genitals, the spermatic cord in males, or the round ligament of the uterus in females passes through. And so this right here is the inguinal canal. Here we have the spermatic cord. This must be a male. And you can see here the inguinal canal, just highlighted in that diagram. But why do we need to know about this? It's a very common site of hernias. As you can imagine, there's a hole through the abdominal wall, and if there's a hole through the abdominal wall, well, what is a hernia? It's organ going through muscle layer, so this is a site of hernia, so it's a good thing to know about. All right, so what are the boundaries of the inguinal canal? The floor boundaries are made up laterally by the inguinal ligament, right, so right here, and then the other floor of the inguinal canal is the lacunar ligament, which is kind of an extension of the inguinal ligament, which we can see right here. All right, the anterior wall boundaries, so I found this diagram online. Anterior wall boundaries, we have medially the aponeurosis of the external oblique, so right here. All right, so medially, this is our inguinal canal. Medially, we have the aponeurosis of the external oblique. You can see this is the flat tendon of the external oblique. Laterally, we have the superficial aponeurosis of the external oblique. That's this guy, right? Just more flat tendon of the external oblique. And then deep to that, we have our internal oblique. And so fibers of the internal oblique, and specifically you have the cremaster muscle, which is this extension of fibers from the internal oblique. And this is going to be what this is what lifts the testicles in males based on temperature to thermoregulate the testes. All right, posterior wall boundaries. We have medially the aponeurosis of the transversus abdominis, which you can see here. So this is the transversus abdominis muscle. And so posterior wall boundaries, you can see we have this guy medially. And then we also have the internal oblique aponeurosis, which is this guy. All right, so posterior wall boundaries. And then laterally, we have the transversus fascia, which is this guy, transversalis fascia right there. And it has our deep inguinal ring overall. All right, and that's what this is saying. Can you look and describe the deep inguinal ring in its relationship to the transversus fascia? Well, this is the deep inguinal ring. It's just basically the transversalis fascia extends to cover the spermatic cord. So this ring is just transition from this fascia to fascia, that same fascia covering the spermatic cord at this region. All right, so here's just a quick summary of the boundaries of the inguinal canal. Laterally, the floor, inguinal ligament. Medially, the floor, lacunar ligament. Anterior wall, laterally, external oblique aponeurosis, and internal oblique fibers. Medially, external oblique aponeurosis with the superficial ring. And then posterior wall, laterally, the transversus fascia. And then medially, the conjoint tendon, which is just saying the transversus abdominis and the internal oblique. Their fascia comes together and forms the conjoint tendon. All right, so can you describe the descent of the testes and the acquired coverings of the spermatic cord? All right, so as the testes descend, we can see we have this ligament called the gubernaculum, which connects the testes to this fascia plane. And so this guy shortens, and as it shortens, you have the testes descend, and so the testes and ductus deferens are drawn into the scrotum through the inguinal canal. The acquired coverings are better shown in this diagram, but the innermost covering, aka the internal spermatic fascia, is from the transversalis fascia. Right, we can see here, kind of makes sense because this is the furthest back. So the transversalis fascia gives us our internal spermatic fascia. Then our second covering is our cremasteric muscle and fascia, which we said comes from the internal oblique muscle fibers, and it raises the testes for thermoregulation. It's innervated by the genitofemoral nerve. I may have mispronounced that. And then we have 3 is the external spermatic fascia, the outermost layer, and this comes from the aponeurosis of the external oblique, from the fascia, aka the fascia of the external oblique. All right, so that brings us finally to the inguinal triangle, aka Hasselbalch's triangle, and hernias. Basically, as we alluded to, because we have a hole in the abdominal cavity to allow our spermatic cord to go through, this is a relatively weak area, and so it's commonly the site. This Hasselbalch's triangle, inguinal triangle, is a site of hernia, and hernia again is organ going through a muscle wall. And so this inguinal hernia is more common in men than women, and we have 2 types. The first type is indirect inguinal hernias, in which case you have basically abdominal organ going not through the through the inguinal canal. So indirect inguinal hernia is going through the inguinal canal, or organs are, and direct inguinal hernia is not going through the inguinal canal, but going through the abdominal wall. And so here we have the inguinal canal is right here. It's not going through the inguinal canal, it's going directly through the abdominal wall, but it's still in the inguinal triangle, which again is still kind of a weak area. And so this is a direct hernia because it passes through the abdominal wall, not through the inguinal canal. Here we have organ coming into the inguinal canal, and so this is an indirect inguinal hernia because it passes through the inguinal canal. All right, and so our surgical scenario, we have a 62-year-old male is examined by his primary care physician, chronic pain in the right groin region, which worsens when standing for long periods of time. A bulge in the right inguinal region is detected. During physical exam, that can be reduced, and a positive cough response is obtained. The patient is referred to a surgeon and later undergoes right inguinal hernia repair. What's the difference between direct and indirect hernia? What type of hernia did this patient have? All right, so mentum pulled into the right inguinal canal through the deep inguinal ring. All right, so this patient's hernia is an indirect inguinal hernia because it exits the abdominal cavity through the deep inguinal ring, which we see here. And then what are the borders of Hasselbalch's triangle? Medially, we have the rectus abdominis muscle, laterally, the inferior epigastric vessels, and then inferiorly, the inguinal ligament. All right, so that's it. Very long, but hopefully that was helpful. Try to be thorough as always. Just a reminder, here are the muscles that we need to know for this lecture and for this lab. All right, good job, guys, and remember, this is hard. You got this, and we'll stay positive. Good job.